Hi, everyone. I would love to welcome you to our Community Engagement Series event. My name is Dr. Priscilla Medeiros. I'm the Knowledge Mobilization and Community Engagement Specialist at the Edwin S.H. Leong Center for Healthy Children. I'm very excited to introduce our speaker today, Dr. Ripudaman Minhas, who is a developmental pediatrician at St. Michael's Hospital, Unity Health, Toronto, as well as an assistant professor of pediatrics. He's the Director of Research for the Department of Pediatrics at St. Michael's Hospital, as well as the founder of the Our Kids Health Network, which is a community-led social media-based child health promotion program that delivers evidence-based health information online for families with diverse cultural linguistic identities. Dr. Minhas focuses on the use of community-based participatory research methods to engage with communities to co-design and deliver interventions to support parents and caregivers from marginalized communities in supporting their children's developmental potential. His presentation today will discuss the importance of embedding equity and inclusion in research design, as well as share his experiences engaging with community partners and working with refugee and newcomer families to support children's developmental well-being. I'd love to hand it over now. Thank you so much.
Thank you so much, Dr. Medeiros. Hello, everybody. I'm going to just see if I can share screen. So if you just bear with me for a moment, and we might have to do that a couple of times as I shift gears during our hour that we have together. So hopefully that is showing up for you there. Oops. There we go. And in case something is not working from an AV standpoint, or my microphone or my headphones stop working, Dr. Medeiros, please let me know. And so, hi again, everybody. So my name is Ripudaman Minhas, as was just mentioned. So I'm a developmental pediatrician clinically at St. Michael's Hospital at Unity Health Toronto. I work with families of children and youth with neurodevelopmental concerns and disabilities, many of whom have encountered multiple axes of marginalization due to aspects of their identity. So sometimes that can include their immigration status, and being impacted by poverty, their racial identity, mental illness, and more. So over the time that we have together, I'm hoping that we'll be able to have some interaction either through the chat, or I would love it if you could use the QR code here to meet me on my Poll Everywhere page, or you can use your phone. You can text there. It says to 37607. You can, if you put in those words there, you can use that, or if you're at a computer or device, we'll put in that link as well, so we can kind of participate together as a part of that. So again, thank you for the opportunity to speak about this, and also for your reference, that embroidery that's in the background here of this slide is a traditional Punjabi fulkari, is what it's called, that type of embroidery, and that was actually hand embroidered by my late great-grandmother-in-law, Sardani Bachan Kaur Virk, and fulkaris like this would sometimes take many months and many hands to complete, and this one is very big, and it hangs in our home, and it's a symbol of, to me, of resilience and synergy, and how people can come together as a part of a community to create something really beautiful. I also think it's important for us to begin important work with acknowledging where we're located, both to ground us in our conversation and in this moment, but also to remind us of context and of humanity, and our responsibilities as participants in our healthcare system. So I wish to acknowledge this land on which we're meeting virtually today. For thousands of years, it has been the traditional land of thriving and rich communities, including the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. I think this comes with an important responsibility for each of us and our institutions to commit to learning about the exploitation, enslavement, colonization, genocide, and marginalization of Indigenous communities, and how it has contributed to the systems in which we participate in, and many of us continue to benefit from, perhaps unintentionally, but even today. I also understand that the practice of land acknowledgement is only a very small step in the long journey towards true and meaningful reconciliation, which will require dismantling and rebuilding these systems together. I myself am raising my family in Treaty 19 territory in what is now known as Peel Region, And I'll pause for a moment for the folks in this room to think about the space that you're in, where you work and live, its history, its legacy, and your relationship with that land. And so I was wondering if maybe we could just start off with the folks in the room sharing a little bit in this online poll, maybe 2 words. What is the focus of the work that you do? If you could put that into 1 word, if possible, and also where are you based? So if that's a geographic space, that'd be great. So you can either scan that QR code on your phone, or I believe we have the link in the chat. If you could go to that, and I'm going to try to shift gears over to my other screen, and we can take a look at what you have to say. So I'm going to stop sharing for just a moment, and then I'm going to try to share this other screen. Great, thank you for folks who are participating. So I'm seeing research, I'm seeing the word health. So with this sort of word cloud, the more commonly the word is being entered, the bigger that word is. So I'm seeing health, child. I see folks identifying as pediatricians, working in a perinatal space. I see equity. I see the word tertiary. So different locations within our system in terms of health and well-being, children, family, different disciplines. Oh, that's really exciting. Great. Awesome, thank you for that. We're going to shift back to the slides for a moment. And so, when we engage in work as humans, we take all of ourselves into that work. So whether it's a discussion like this, or whether it's working with children and youth in a clinic space, or in a program, or in a research project, it's really important to think about, our identities and the identities of the people with whom we're working. So our lenses really do impact our work in all of these spaces. So I invite you to reflect along with me in terms of, what you bring into this work. So for me, I would say that my work is impacted and informed by my experiences as someone who is a healthcare provider and a consumer. I identify as a cis male, a settler, a person of color. I'm a parent. I am a person with a post-secondary education in Canada in healthcare. I'm stably housed and employed, and I have family members who have chronic health issues, who have mental health diagnoses, developmental disorders, and individuals who are refugees or internally displaced peoples as well. And so I'll pause for you to think to yourself a little bit of, what do you bring of yourself into the work that you do, and perhaps into our conversation today? And how do you view yourself in terms of your positionality around privilege and disadvantage, or centeredness, or marginalization? And while you're doing that, I'll bring up this slide. So many of you might have seen some version of this in the past. So this is by, this slide tries to capture the work of Dr. Kimberly Crenshaw. And so the various axes of a person's identity and related to the social value that's been placed on each can really impact how we participate in our roles. And on the flip side, can impact how our clients and patients and research participants participate in this work as well. So we'll come back to that concept. So, in the time that we have together, I'm hoping to talk about community-based participatory methods. I'll remind you about why and how to engage with communities as partners in the work that you do, and some of the experiences I've had with that. I hope you'll leave with ideas for and opportunities for meaningful engagement with the communities that you work with, and to improve the outcomes of kind of the various aspects of health of individuals and communities as well. And so a little bit of a spoiler alert, this is what I'm hoping you'll take from the talk, really, that is that historical methods of engaging with communities are inequitable, that we really need to think through them and rebuild that communities themselves are powerful social entities that have unique strengths and knowledge and values and perspectives that need to be honored, and that our teams would all benefit from updating our strategies and continuing to help them evolve in terms of how we engage with communities as partners in our work. So we're going to go back again to that poll everywhere. So Dr. Medeiros, if you're able to put that into the chat for folks who are just joining us again. But I'd like us to think a little bit about where we're situated in terms of what community means to you in the work that you do. And that's a very broad term. So for some of us, that could mean a specific diagnostic community. It may be geographic encatchment. It may be related to something else. So if you could share it in the poll everywhere. And again, I will meet you there in just a second. I'm going to share the screen for that. Here we go. So if you could enter in a little bit of what the word community means for you in the work that you do. So rare disease. And that's very interesting, I think, in terms of, the rareness of disease, from what I understand, particularly with diseases that are sometimes overlooked or underrepresented in terms of funding and research, is something that brings people together in a way in terms of being overlooked, from what I understand from my colleagues that work in that space. Compassion, inclusion. I'll give it just another moment for folks to share their thoughts about what that means for the work that you do. Participation, I like that word. I like many of these words. Great. Collaboration. I like word clouds, especially with something like this. I feel like they make beautiful art as well. And that visual representation is so nice. So maybe we'll shift back again. Thank you for everybody who's entering their responses. If you're still entering them, please make sure you press send, and it'll take us, it'll capture it afterwards as well for our purposes. And then so I'm going to go back over to the slides. So, as we think about communities and the work that we do, and some of those really nice sentiments that that people were putting into our word cloud, I think it's important for us to think about our roles. So for the folks that are in this Zoom room right now, I'm thinking about how you interact with the communities that you work with. What is your role? So whether you're a clinician, a policymaker, an administrator, a researcher, an advocate, someone who comes into it with advocacy through a lived experience lens, it's really important to think about some of these relationships, and particularly around the dynamics of power and privilege and position within that community, and thinking about how various people participate in that system. So some of you may have seen, again, this depiction before. It's sometimes called a power flower, thinking about the various petals of this flower schematic where power and privilege and position tend to and historically have lived at the center of this flower. And you've got different axes of identity kind of coming out from it, which are represented in those petals. And there's many other ones that could be assigned to it as well. And the closer you are to the middle, the more centered you are. And then the further away you are, the more marginalized you might be as well. And so it's important to think about ourselves and how we situate ourselves in this, and then also in terms of the folks that we work with as well. So if you work with children and youth with chronic illness, for example, how would their intersectional identity impact their participation and their ability to perhaps even advocate within the system or to participate in the system, if they were a woman or a Black woman, a Black trans woman, someone with a physical disability, someone of refugee background, someone whose primary language proficiency was not the dominant language, which for most of us in our system is English. So, just a reminder, and I really like the schematic, but just as we take all of ourselves into our work, as we talked about a moment ago, so too do the people that we work with as patients and clients and research participants, and they bring all of themselves into that space as well. And I think it's important to think about, who participates in the system, how they participate, and are there folks who are left behind whose voices are silent or silenced by the systems that we participate in. And so traditionally and historically, the institution of healthcare and its interventions and delivery models and research agendas and training approaches and values have really been led by healthcare professionals, by research funders, by academic institutions, healthcare corporations, and government bodies. And these groups, have historically created interventions or delivered programs that were to, for, about, or on intended user communities, sometimes referred to as target communities, which I don't like as a term. And so inherently, we understand these approaches are prescriptive, they're biased, they're skewed by the perspectives of individuals. And if you think about where many of those those people who are in these roles historically lived within that flower, there's a risk there in terms of the biases that have been brought in historically around power, position, and privilege. And there's a risk of imbalance in that approach and further perpetuating inequities and oppression, and even if it's well-intentioned. So in recent years, there's been an interest, as many of us in this room know, in trying to understand and incorporate perspectives of patients and families and communities. And I challenge us to think about, can we shift that power over to a power with and create a model of partnership in trying to do this, and understanding that may be out of the comfort zone for many of us and our institutions in terms of how we were trained and how structures have been built historically. So asking you to think a little bit about, how would we rebuild that system? And we won't do a poll on this, but maybe this is a journal prompt for you to think about. But if you were to pause and just think about, I imagine a children's healthcare system where ... how would you complete that, or how would you think about what you'd like to work towards? And this is an interesting and exciting time in healthcare. As we're in this part of the pandemic landscape, and so thinking about the many painful truths, but also opportunities that have come up through this time. And so I love this quote. Some of you may be familiar with it, but I really think I really like what it illustrates. And so it's from Sonia Renee Taylor, who tells us, as we think about the pandemic, we will not go back to normal. Normal never was. Our pre-corona existence was not normal, other than we normalized greed, inequity, exhaustion, depletion, extraction, disconnection, confusion, rage, hoarding, hate, and lack. We should not long to return, my friends. We are being given the opportunity to stitch a new garment, one that fits all of humanity and nature. So where do we begin with this? Or where do we continue for those of us that are already working in this space? And I think it's important for our institutions to create safe and brave spaces and channels to hear the voices that need to be centered. And this can bring up a range of different emotions for us. As I was saying, it can feel uncomfortable, but hopefully it does bring us to a space where we feel inspired for change. And it does require also, unlearning and relearning some of what we think we know or what we've learned. And I think for our clients and patients, it's important to think about, approaching diversity and disparity, not with judgment, but with humility and curiosity. I think there's a lot that we can learn from one another. And I think that's one of the most beautiful parts about community partnerships. So, I ask you to think a little bit about how can we do better? So when I was talking about that journal prompt a moment ago, what is it that you imagine from the space that you're in and the people that you talk to and the work that you do? How can we do better? And again, thinking a little bit about whose voices are not heard or are silenced or have historically been silenced. And we know that historically marginalized groups have experienced trauma in many forms at the hands of our institutions. So this includes medical experimentation, racism in its many forms, colonization, transphobia, ableism, and many others. And so I think it's important, again, to think about the disproportionate impact these barriers to care have and continue to have even today, in how different communities may participate in or perceive healthcare and its related institutions as we think about academia and research as well. So One important concept that our group has really been thinking about is representation. I know that's on many people's minds right now. So I think, we can think about that in different ways, but important to think about, your catchment, your population of interest, whether it's geographic or diagnosis based, and taking a look maybe at, the data. So that may be geographic data related to like the census. It may be other key demographics of the variables, demographic variables of the folks that that you are trying to support or create programs for. So for example, thinking about different aspects of identity. So if you've got, if you're looking at different things such as Indigenous identity, Francophone identity, caregivers that have less than a high school level of education, or maybe a single caregiver, thinking about, do we have data on what their percentage or proportion is within the community that we're trying to work with, and how many of them are actually making it into our clinics, our programs, our studies. And so pausing for a moment just to think about that aspect of representation, I think, is important. And so again, just reminding us about, who's accessing our services, who's not accessing our services is the question that comes from that. Who is it that's missing? Has that intention to come in, maybe referred in, but doesn't make it in? And what do we know about them? And from a personnel standpoint as well, who is it that's designing our programs and services? Again, that agenda I mentioned earlier, and who's providing those services? Who are the faces and people that are interfacing with those community members as they come in as well? And that leads, of course, to an important question of, really how robust are our data systems in capturing these data? And when our communities are not participating in programs that, from our standpoint, we're very carefully trying to design and cultivate, that's why is that happening? And that's something we need to explore further. And asking why really helps us to understand how individuals and communities participate in the healthcare system, what's working, what's not working. It gets us one step closer to understanding their lived reality, their perspectives and barriers, and their priorities. So I'd ask you to keep in mind, it's not people that fail, it's not communities that fail, but really systems that fail. And so thinking about the systems that we all participate in, again, how can we rebuild and do things a bit better? And when we're thinking about asking why, it brings up the question, really, who should we ask? How do we do that? So what are some ways in which one might go about engaging with communities to ask or to understand, what's working, what's not working? So conventional systems have typically involved things like board meeting style interactions or interviews, which we now know can feel interrogative or interrogative, but really do have a power dynamic to them. They can feel very Eurocentric in nature, or very corporate and cold perhaps as well, and can make potential participants feel isolated or excluded. And so some of the things that we've been thinking about with our group is, other ways that we can try to engage with communities. And here are a few quick ideas, and hopefully as our conversation evolves, we'll have some time to hear from folks in the audience about what you think has worked as well. So community mapping is really important for us. That's involved looking at dynamics that play within a community system, including identifying trusted leaders or advocates and representative agencies or voices that are proximal to kind of the general community experience and perspective, and trying to engage with folks who can speak on behalf of or with a general sort of consensus of a community. Social media, I'll talk about in a little more depth in terms of some of the work that we've done, but it allows for easy, quick interaction and can make participants feel generally safe and anonymous if that's important to them. Priority setting partnerships are really important, again, thinking about what space you're in relating to this, but essentially this involves convening a group of stakeholders to inform priorities for your program or to help set an agenda or mandate. So again, sharing that microphone a little bit. I'll talk a little bit about that. Community advisory board. So again, we'll talk about this, but essentially thinking about groupings of community representatives, either as individuals with lived experience or as representatives or as agencies, to inform your work going forward, and often steering and guiding that. Thinking about representation on your project team. And this can go beyond just hiring a research assistant from your end user or intended community, but to actually embed representation into the various aspects of your program's design, implementation, evaluation, and refinement as well. Focus group consultations do have a role. I think sometimes that's with more specific dimensions of a project or with specific questions you may have. I think it's really important to think about flexibility in terms of creating safe and accessible settings. So for our work with young parents, this has meant engaging sometimes on playgrounds, having group play dates, having tea parties, depending on, again, the perspective that a participant may be bringing in. We've had, plenty of play dates and tea groups sitting on the ground, having snacks together and talking about priorities for folks as well. So again, something that may feel different for us in the work that we do, but meets communities where they're at. And for those with limitations on time or sensory impairments or limited literacy or difficulty engaging in group settings, which can be a barrier for some, it's important to consider other individualized methods of engagement, either with your team live, such as a virtual interaction, or electronically, or through surveys as well. So again, being flexible about how we think about what engagement can look like. And folks often ask, well, my community doesn't care about what I care about, or they don't prioritize this information or these services. And so that's, again, an important time to pause again and to think about why. And what is that misalignment that might be occurring in terms of priorities? Is there a lack of information that your team has as an academic partner or a healthcare partner, or is there something that our community partners may not understand or may not have knowledge about? And I think that brings in some of our role around health promotion and building capacity and sharing knowledge about why we think certain things are important, but coming into, again, that situation with curiosity and humility as well. And so creating space for input from communities really helps us to understand their strengths, their priorities, barriers, and then relevant content in the context of their health values and goals as well. Understanding that those might be different from ours, as I just mentioned. So, thinking about what are the right or ideal or preferred ways to communicate and helps us to understand and address if there is mistrust, and also what their priorities may be, and also capacity to participate in our work, which we may think is important at that time. And we know that engagement with families and communities as partners, and I would say ought to, it ought to be kind of embedded throughout this framework, but really should be happening at all stages of the process in addressing health needs through interventions, all the way from mapping out our initial concepts to mobilizing the knowledge that comes from your processes and advocating for change. So I had mentioned this term CBPR before, and I know folks in this room may be familiar with it, but just to summarize briefly, community-based participatory research is a methodology really with the potential to make substantial contributions to improving health and well-being for communities that have been traditionally disenfranchised or marginalized. And it also has a really beautiful capacity to build capacity within these communities as well. One of the underlying processes here is really that CBPR attempts to engage community members as active and equal participants in every phase of the research process, ideally, and facilitates trust building. It enables rigorous and ethical conduct of research with a community as well. And that blue box there, I really like how that summarizes it, but really that it honors and recognizes the community as a social entity with its strengths, its own knowledge and power. Again, an equal partner in the process when we're thinking about our different spaces around program design, research and evaluation, and also revision of the work that we do, because a lot of this, as you can see, it's a cycle on that schematic that we have there. And folks again in the room may understand this, but it can take time and a lot of more upfront costs to ensure that there's equitable access to participation for community members, thinking about some of those traditional barriers as well. But we know that it does enhance community relevance of the programs that we create within that context. It increases reliability and validity of measurement tools that may be created as a part of that. It improves response and retention rates, increases accuracy of interpretation of data that may have more nuances to it. And also, I think really important to recognize that it creates sustainable community change by creating improved trust and rapport with communities as well. But how this gets put into practice can be tricky. So in a recent scoping review that our team had done, we looked at the participation of refugees in community-based participatory methods. And it was found that really the vast majority of people with lived experience participating in studies and policy design was in different parts of the process. So some were studies where the community partners were involved in identifying the study problem or the design, with recruitment and data collection. But we also found there was lesser involvement in the knowledge translation piece and with scale up. And interestingly, we didn't really find cases mentioned where these individuals were involved in funding acquisition, which actually, might be a really great opportunity for community members to build capacity within that skill set as well. So something just to think about as we think about different stages of the work that we do. Is it possible to engage with community partners early on in helping to guide us in our work, but also in terms of what is the learning and capacity building that may come in a reciprocal sort of way. So one of our group's projects is entitled the Maple Circle Project. You may have heard me talk about this before. I feel very passionately about it, but we attempted to apply CBPR methods to create a parent support program for families of refugee background in Canada. And the program focused on supporting families with children that had developmental or behavioral concerns in their early years. Some of this got kiboshed by COVID, but I think some of the initial stages are important learning points for us. So we understand that families of refugee background may have complex, multi-generational mental health and developmental needs that are not accounted for in current programming frameworks. So currently, in our clinics, we would be referring families in this with these characteristics to existing parenting programs, most of which are built to serve mainstream resource abundant families, often using very Eurocentric frameworks around what parenting ought to look like. And the existing programs did not account for the unique mental health, resettlement, and cultural profiles of families of refugee background. So for this project, we engaged community partners with lived experience all the way from the definition of the question to funding acquisition as well, methodological design consultation, and then kind of going through an iterative sort of cycle around designing a potential intervention as well. And some of our team members with lived experience, or there are community partners who became team members, shared some of these quotations. So one person shared, as a newcomer, a mother and a researcher from back home in quotations, it was great to work on this project. It helped me help others because I went through the same process with my family. I learned a lot about writing research proposals and grant submissions that will help me in my career. And then we had other folks as well sharing that one person said that their parents had been refugees to Canada, and working on this project, they thought about them. They thought about how great it would have been for them to have this kind of support a generation ago. And another person shared that working with these participants allowed me to advocate for families of individuals with disabilities the way I wish my family had been when my sister was young. So again, that lived experience piece, I think, can be really powerful in the work that we all do and the people we bring into our projects too as well. And so our community partners for this included parent and family partners with lived experience, and also community agencies that work in this space. And our academic partners included St. Michael's Hospital, Women's College, and the Harvard School of Public Health as well. So again, thinking again about how academic and community partners can work together. And it was interesting to think about, or to go over what we learned. So just in a nutshell, some of the initial consultation data we grouped in 3 key themes. So program topics, facilitators and barriers, and program logistics for this potential parenting program. So for program topics, parent and community agency stakeholders identified a need to cover topics on typical child development, family resettlement needs, including seeking employment and navigational difficulties, advocating for children in school and the community, and parenting in what they described as a Canadian context, but really after resettlement, which included confronting racism, parental self-care, and discussions on corporal punishment and behavioral management and cultural kind of discordance around some of that as well. So interesting to hear that, especially because it's so different from the pre-existing paradigm around program. And then stakeholders also identified barriers to participating in existing programs, including language difficulties, which we kind of anticipated, but also competing responsibilities and having to care for other family members, having a lack of awareness around existing programs, and also the need for including frameworks that were anti-racist and anti-oppressive. And the discussion around program logistics was also really helpful. Families often sharing that they actually preferred being in multilingual and multicultural groups. Families shared that they liked being able to network with people who had resettled in Canada, perhaps from other parts of the world. And they liked being able to be a part of a diverse and rich parenting community, something that they had lost after resettlement, particularly as young families that had been displaced forcibly. And so they said they liked the idea of meeting outside of their home in a central place because it gave them an opportunity to get a bit of a break from home sometimes. And they thought that this would have a positive impact on their well-being. And they also reminded us that some of the meeting rooms that had been used for pre-existing programs might have been in a community center or an industrial type meeting space or a corporate type meeting space. One person had shared that a program they had participated in was in a basement, and it was reminiscent of places where they had been experienced trauma pre-migration as well. So really important to hear about some of these messages and things, again, that our team hadn't thought about in thinking about what to build into our programs. And so just to wrap that up, but that program is now being implemented into our virtual delivery platform in light of COVID. But stay tuned for more about that. And if you want to read more about that, I shared that paper earlier, but I'm happy to share that again afterwards. Another option that our teams had some success with and is really excited about is digital engagement. So, if we want to get to know our communities and their priorities and perspectives and values, we really need to go with our. And so this is a bit troubling, but not totally surprising, but apparently our numbers from last year show that adults spend an average of nearly 2.5 hours per day on social media globally. And so though this has been a bit of a tricky space for healthcare providers to navigate, the potential to engage through social media and platforms is really huge. And social media platforms are just that, they're social. It's a place to share information about your program, your research, your providers, the services that you offer, and also a great place to ask for information about communities' priorities, their perspectives, barriers, and health information needs as well. So I'm going to talk for a few minutes about our team's work in using social media in sharing child health and parenting information with diverse cultural linguistic communities. We have a project we've created that's called the Our Kids Health Network. And so, and some of our key learning around social media and equity in digital spaces includes actually following your intended communities. So, looking at which platforms they use, what languages they participate in, what their language and literacy and accessibility profiles are like, and what sort of visual representation on screen will help engage and build with rapport as well. So social media has been a space where we've been doing a lot of learning. But this all started just over 2 years ago in the height of the pandemic. Our team created an online parenting support resource, which we piloted with the Punjabi diaspora community called Punjabi Kids Health. And this came from watching really the unearthing of grave disparities in how racialized communities participate in our healthcare systems, as we saw at the height of the COVID-19 pandemic, including in my home community of Brampton, Ontario. And so across our platforms on Instagram, Facebook, and TikTok, Punjabi Kids Health has grown over the last 2 years to more than 125,000 people following. We try to share evidence-based, peer-reviewed content in the space of child health promotion and caregiver mental health. It's translated and adapted, so both in English and in Punjabi, and it's shared on social media with trusted messengers or healthcare professionals who reflect the intended community as well. And we know that when you receive health information from someone who has some lived experience, there's a lot of data that shows that you're more likely to take that in and to apply it to your own health behaviors as well. I'm going to share a video, so hopefully this works. And I feel like this guy says it better than I do, so I'm going to just press play and cross my fingers.
Improved trust and with Communities
There we
who
go.
are marginalized benefit from having healthcare and health information given to them by people who have some shared lived experience. This leads to improved trust, and with that, then improved health outcomes for individuals and for communities. Hi, I'm Dr. Ripudaman Minhas, and I'm a developmental pediatrician at St. Michael's Hospital, Unity Health Toronto, and I'm the medical lead and founder of Punjabi Kids Health, which is a digital health literacy program for families that are part of the Punjabi diaspora. During the pandemic, it became really clear, especially in my home community in Peel region, that different cultural linguistic communities were participating in the healthcare system and being marginalized in different ways. And so we really wanted to create evidence-based health resources that were accessible for families. And as a pediatrician, it made sense to look at children's health and parenting. And we know that, especially for young parents, they are accessing health information online. We wanted something that was available to them, and something that was accessible both from a linguistic standpoint, but also culturally adapted as well. We've got more than 50,000 online community members or followers. We get lots of great questions which help us tailor our content. So that's really something we're trying to do, is make sure it's participatory. So we get questions that help us guide, where should we go with the project? What are topics we should be covering? What are myths we should be trying to debunk?
The COVID-19 vaccine helps our body fight the germs.
Families have ongoing questions around the safety of the vaccine for children, especially around some of the side effects we had been hearing about early on, and then related to that, also the long-term impacts as well. So we're trying to share evidence-based information and helping families have the information need to be able to make the right decision for themselves. It's been a huge success over the past year, and it makes us wonder about what...
I'll pause there. I'm sorry, that was a little bit laggy.
Improved trust.
Oops. There we go. So like I was saying, that's one of the things we really enjoyed about social media in being able to engage with communities, that it's live, it's dynamic and evolves in real time. So we're continuously gathering data and engaging with online community members. We don't like to call them followers, as I was saying in the video, because it's really our team that follows their needs. And so based on community questions and social media analytics, we've covered a range of different topics, some of the ones that you're seeing up here, which include COVID, virtual school, specific to the Punjabi community. We also talked about the mental health impacts of the Indian farmers protests that were happening last year. And then also had a Mother's Day panel about maternal mental health. And also a back to school series on Instagram as well, with an Instagram live series we had done last year. And our community engagement methods online have included a few of these things. So online polls, live Q&As, in which we actually gather data from the questions that people are typing in as a part of that, and keeping track of our direct messages that we get. And also looking at social media analytics, taking a look at what is the content that's doing well, that is getting a lot of likes and shares and follows, and can we create more of that if that's something that folks are liking. We've also engaged with community agencies such as children's aid societies and school boards, and then also some focus groups as well to get a more deeper understanding of what's working and what's not working for people who are participating in this program online. And then also really helpful to think about community feedback about topics that are of interest, like I was saying, delivery modalities as well. And then there was an interest in having more streamed content. So content that might be specific to the experiences of male or female caregivers in their roles as they perceive them, for grandparents, and also for professionals that work with children in this community. And so building on this initial success with this first community-led chapter, we received funding from the Public Health Agency of Canada to scale this up and adapt this model to other high priority communities as well. So this past November, we just celebrated our half birthday actually today. So this past November, in partnership with the Canadian Pediatric Society and also the World Health Organization's Digital Health and Innovation branch, providing mentorship as well, we launched an overall network of channels, which we call the Our Kids Health Network. And we have a total of 10 cultural linguistic channels that are adapted and community led. So these are for individuals and families that may identify as Ukrainian, Cantonese or Mandarin in the Chinese communities, Hispanic, Filipino, Tamil, Arabic, Inuit, or Black, communities. And so each chapter is developing a unique curriculum. So not a cut and paste in any way, but really adapted to the priorities of each community with providers from those communities. And we just crossed more than 250,000 members or followers across these platforms. And our approach generally has been starting with a weekly topic. So it could be something like nutrition or picky eating, child and youth mental health, toddler well-being, oral health, something like that. We usually will post 2 or 3 reels or TikTok style videos, some infographics as well, depending on how people want to take in that content. And then we also will have special days that we might observe, like the International Day of the Girl Child and World AIDS Day, International Autism Awareness Month, etc. And my favorite actually as a part of our curriculum is the You Asked Us Week that we do every month. And so with that, our practitioners will create short, usually 1-minute videos asking, answering questions that people write into us as well. So really trying to make sure that we include that in terms of people's questions and priorities. And again, we're trying to make sure that we respond to the priorities of the community. Here are some samples here of some of the work that that's been shared recently. So from our Black Kids Health channel, we had a video on how busy parents can make time for their kids. From the Arabic Kids Health channel, there is a topic on supporting your child's mental health at home. And we had also actually created some content very soon after the awful earthquake that happened in Syria and Turkey around supporting your child if they see distressing news in the media for the AKH channel. And then there's also a post there from the Hispanic Kids Health channel about breastfeeding. And we'll share links afterwards if folks do want to follow along with any of those channels or our journey. But here are some quotations here really about people sharing some of their questions and also what they think we're doing well or what we could be doing better. So again, very quick, low touch sort of engagement that we've been able to do. And we talked about representation and engagement in broad sort of aspects of our work. And so we found as we were creating our visual content that we didn't have stock images that we could use that showed BIPOC providers and diverse families. And so we had a photo shoot back in the fall where we invited in families from diverse backgrounds and practitioners from diverse backgrounds so we could create images to be able to use, which was really fun. And we're going to be doing a second round of this coming up soon. And then also our communities participate in co-development of the curricula that we have. We've hired a really rich and diverse team in terms of their identities and their professional backgrounds that help to steer the project. And also in vetting and trialing our website to make sure it's user-friendly, and we have an app coming out soon too, actually. And then also the visual representation of each channel you'll see looks different as well. So we were able to work with artists from each of the communities. An example here is for the Inuit Kids Health logo, where we had artists from each of the communities help us come up with color palettes and motifs and art that would resonate with community members as well to help with engagement and to honor their experience as well. And each of the chapters has a community advisory board with key community agencies to help us in guiding our work. I mentioned we were going to talk about community advisory boards, and I just, I was talking about the ones that we have for our kids' health. And I think this is something you really, a lot of organizations have recognized the value of in centering lived experience and trying to create these sorts of boards. I think it's really important here. I think a caveat is, setting up an echo chamber. We really need to make sure that we have a broad range of voices represented, not just folks, who are able to participate because it's convenient. And sometimes that is, again, people who live closer to that center of that flower I had shared earlier. So I think really important for us to think about, does our community advisory board look like the people that we're trying to create content for or our programs for? Sometimes, participation in activities and in our work requires time away from work or family. Employees Eurocentric or some of the historical frameworks around engagement, which I mentioned earlier, around meetings and boardrooms and timelines can be hard as well, and can also bring in complex social dynamics around individuals who are in the room, can make people feel disempowered at times as well. And so really important to think about that, and also really important to think about compensation for participation, just like everyone else in the room, for our community partners. So again, important to think about different ways that we engage. I'm keeping an eye on time, so I'm not going to ask you to fill out this part of the poll, but we can come back to that as a part of our discussion, I think. But I'll wrap up my part just by saying, you know, some of the lessons that I've learned really is to engage early and frequently as equal partners with community partners as a part of our processes. Again, whether you're thinking about healthcare, whether you're thinking about kind of service delivery, whether it's research, also going where your community is and meeting them there. Again, which may be outside of our comfort zones in terms of where we've trained and the structures that exist, thinking about voices that are underrepresented and trying to pass that microphone to them, thinking about proximal voices. So if it's hard to engage with communities and individuals with lived experiences, then sometimes a close proxy might be agencies and practitioners that work with them as a bit of a proxy for now. And also approaching with curiosity and humility as we think about some of these things. There are some resources around best practices in this space that I find really helpful, including from our team here at Unity Health, communityresearchcanada.ca, and then also for our family partners and community partners, there's a great course of around family engagement and research as well. So our families and community partners are not just thrown into these roles, but are given education and frameworks around their participation and their rights as well. I will pause there. And also, as I pass the microphone back to Dr. Medeiros, thank also the community behind the work that we do, some of whom are named and pictured here. I will pause there.
Thank you so much for such an incredible presentation. I was making notes as you were speaking of things that I found exciting, relevant to the work we're doing here at the center, and potentially follow up with you in the future on. But at this time, I'd like to ask that if anyone has any questions, to either raise their virtual hand or to type their question in the chat. Mindful of time, we can take a couple of questions though. So please feel free to pose your questions at this time.
And I'll stop sharing screen, but if folks do want to follow along with our newsletter, I'll put that into the chat as instead of on screen so people can follow along.
I see we have a question in the chat here. Can you share some suggestions families have given regarding content on our kids' health? And also complimenting you on a wonderful presentation.
Oh, thank you so much. And so, you know, some of the content that's been very interesting, so it's been interesting to hear about, you know, in the broad range of questions that families have. So one of the most popular videos that got, I think, like 4 million views was on how to stop a nosebleed in your child. And then a similar one was how to clip your newborn's fingernails. So it's interesting because it's things that, you know, may be hard to find information on. You may not actually make an appointment to go see your healthcare practitioner about that, or it might be something that's imminent and new. But I'm surprised sometimes by some of the content or the questions that we get. And again, just reminds us of the importance of listening and creating content that's helpful. But there is a broad range. There's also a lot of questions around mental health supports, about families who may be encountering racism within current systems. So we are creating a toolkit for families on how to advocate within the school system as a BIPOC parent, as well, based on some of the questions that we've been getting.
That's fantastic. I'd like to thank Justine for posing that question as well.
Thank you, Justine.
Are there any additional questions from those on the call? Please feel free again to raise your virtual hand or to type your question in the chat. I have another question here for you from Vanessa. I'm wondering what approaches you found helpful to engage participants who speak different languages on community advisory boards.
So, you know, we've tried, that's a great question, and I think really important, and kind of reminds us again about the importance of creating accessible ways for families to participate based on language proficiency. You know, we think about sensory impairments, et cetera, as well. And so, you know, We've had some times where we've actually had interpreter support, which can get kind of cumbersome, but we offer that for people participating in community advisory boards. And the reason I say it's cumbersome is because it can be hard when you've got multiple interpreters in the same room at the same time. We've sometimes we've had many families actually say, they'd like to participate one-on-one with an interpreter. So rather than being a part of a board meeting, but to be a part of a separate setting where we can talk to them, have the time to kind of go through interpretation. Because I think families sometimes have said they feel pressured, the rest of the conversation's happening while they're listening to their interpreter. So having that asynchronous sort of engagement is something that's kind of what we've come up with for now. But thank you for that question.
That's a great response. Thank you, Vanessa, for posing that question. We have probably maybe for another question, I think we have some time for before we part ways. So again, please feel free to type your questions in the chat or to raise your virtual hand. By the sounds of it, we'll be circulating some follow-up information for those on the call to further their capacity knowledge in this space. There was a wealth of information unpacked in the presentation, so I want to make sure that we circulate that to those on the call. Perfect. I think for time's sake, we'll end the community engagement series event for today. If there are any additional questions, I'm sure folks can reach out to you directly and pose them. I'm also happy to pass on those questions as well. Thank you again, Dr. Minhas, for joining us for the community engagement series and not only sharing your experiences, but really honing in on the importance and ways in which we can be embedding equity and inclusion in our research work. I'd also like to thank those on the call for joining us today for this great conversation. This is our last event before we break for the summer. I will be making our speaker announcements in the Leong Center's September newsletter, so please stay tuned. And I'd like to wish you all a wonderful long weekend and certainly look forward to seeing you again in the fall. Have a great day. Bye now.
Thanks again.